Not every question on step 1 and step 2 has to be super difficult. Let's do this one together. A 72-year-old man with a long-standing history of COPD is hospitalized with community-acquired pneumonia complicated by sepsis. He is started on empiric broad-spectrum antibiotics and methylprednisolone. For pain management, he receives acetaminophen and indomethacin alternating every 4 hours. On hospital day 5, nurses note decreased urine output. Laboratory studies reveal a BUN that's pretty high and a creatinine of 3.2. If it's above 2, your kidneys are pretty much destroyed on the USMLE. Urinalysis shows brown pigmented casts and no bacteria. Which of the following medications is most likely responsible for this patient's acute renal dysfunction? Okay, brown pigmented casts is going after what? Acute tubular necrosis. Acute tubular necrosis is the most common cause of acute kidney injury in hospitalized patients in the United States. And we know this acute kidney injury is an intrinsic renal failure because the BUN to creatinine ratio is less than 15. If this BUN to creatinine ratio was greater than 20, then what would it be? That would be a prerenal azotemia. And do you know what was likely causing this patient to come to the hospital to begin with? That's probably going to be a COPD exacerbation. People with a long-standing history of COPD can get URIs that further exacerbate any of their COPD symptoms. And do you know what 4 things we give COPD patients when they're having exacerbation? That's going to be the ABCOs of COPD exacerbation: antibiotics, bronchodilators, corticosteroids, usually IV, and oxygen. This patient had a COPD exacerbation that ended up turning into community-acquired pneumonia. All right, let's go through some of the answer choices. Methylprednisolone. This is an IV steroid that we use a lot of the time in COPD exacerbations. At therapeutic doses, it has nothing to do with the kidneys. This is incorrect. All right, Indomethacin. This is an NSAID. And if someone's taking a bunch of NSAIDs, which type of azotemia do you think they would develop? That's going to be a prerenal azotemia. NSAIDs decrease prostaglandin production. Prostaglandins normally maintain patency of the afferent arteriole. And when we knock out all those prostaglandins, that can constrict the afferent arteriole, decreasing blood flow to the kidney and causing a prerenal azotemia. As we just said before, this BUN to creatinine ratio is not above 20, so indomethacin is incorrect. All right, amikacin, this is the correct answer. This is an aminoglycoside. And by far, the highest yield cause of acute tubular necrosis in all of the NBME shelf exams, step 1, step 2, etc., is going to be aminoglycosides. And what I find happens with a lot of students is that they'll know aminoglycosides cause acute tubular necrosis, but they just can't remember which drugs are aminoglycosides. And there are 5 of them that you need to know for step 1 and step 2. Do you know what they are? That's going to be gentamicin, neomycin, amikacin, tobramycin, and streptomycin. Amikacin is a really weird one because it doesn't have that mycin suffix. So just remember this is an aminoglycoside as well. All right, ciprofloxacin. This is a broad-spectrum antibiotic in the fluoroquinolone class. And by far, what is the highest yield side effect on step 1 and step 2 for fluoroquinolones? That's going to be tendon rupture. It has nothing to do with renal toxicity. All right, cefepime. Which drug class does this belong to? This is going to be a 4th-generation cephalosporin. And some high-yield things about this drug is that it has activity against Pseudomonas, as opposed to a 3rd-gen cephalosporin like ceftriaxone, which does not have activity against Pseudomonas. Cefepime can also cause a disulfiram-like reaction. Do you know what that means? Disulfiram is a drug that we don't really use anymore, and it's used to maintain alcohol abstinence. It works by inhibiting acetaldehyde dehydrogenase and the ethanol pathway. This causes acetaldehyde to build up, causing all of those hangover symptoms that everyone knows and loves. And there's quite a few drugs that can somewhat mimic disulfiram, and cefepime is one of them. And the last high-yield thing about cephalosporins in general is that when they are combined with aminoglycosides, that increases the risk of acute tubular necrosis with the aminoglycosides. So if you have a patient that's really sick and they're on a cephalosporin and an aminoglycoside, they're much more likely to get acute tubular necrosis. Answer is C.